There are other techniques that we can use to treat heavy periods, which can be done in the outpatient setting under local anesthetic or under general anesthetic. The one on the left is a balloon that's inserted into the lining of the womb and contains water that is heated up to about 170 degrees. This scars the lining, and as a consequence, periods become much lighter or disappear. And this is successful in up to 90% of women. This is another mechanism where you deploy a device using radio frequency. And again, the optimal outcome is to reduce periods or to make them disappear altogether. The very good thing about this is just before the menopause, if you have these treatment options, you tend to not need any further treatment for your period problems. And you can avoid major operations like hysterectomies, which many ladies want to avoid by all means. That's all I'm going to say about periods just before the menopause, and I'll now go on to the menopause in more detail. And again, just put down any questions and we can talk about these later. So first of all, what is the menopause? Everybody has their own concept, their own definition, their own perspectives as to whether they welcome it or face it with dread and despair. Essentially, it's a retrospective diagnosis. When you've had no periods for 12 months, then you're postmenopausal. Prior to that time, missed periods, delayed periods for a few months is classed as the perimenopausal time of life. And it's becoming a big challenge for women, especially high flyers who are in big time jobs, BBC presenters, doctors, solicitors, managers. You face board meetings, and the worst thing is to be distressed because of hot flushes, being tired, and focus becoming a problem. Therefore, a lot of people find it challenging. But I would say after today, you should see it as the next chapter, the new chapter of life, because usually your kids have flown the nest. You're less worried about getting pregnant, and this should be a liberating time where you should start to enjoy the next phase of life, which actually is a third of your lifetime if you think about it. Bearing in mind that menopause can occur from any time from age 45 to 55. On average in the UK, it's about age 51 and about 2 to 3 months when most women go through the menopause. So what happens during the menopause? Well, I'll take you back to just before you were born. When you're determined to be a female infant, you have your ovaries already got your bag of eggs. By the time you're born, you have about 2 million eggs in your ovaries. And by the time you get to puberty, this has depleted to about 500,000. So they're rapidly reducing in number. About 4 to 5 years before the menopause, there's a rapid decline in the number of eggs in the ovaries. And as a consequence, fertility becomes less in these women. And the consequence of the reduction in the hormone levels is because of the reduced number of eggs in the ovaries. And eventually, when the basket is empty, you then go through the actual menopause. As I mentioned, it happens over a few years, and in some women, it's just an instant flash, switch off, and everything's sorted. In the UK, currently, there's probably about 13 million women going through the menopause. This equates to about 1 in 3 women on average, and about 1 in 4 of these women will suffer with symptoms. So you can spin it around and say 3/4 of women just slide through, don't know anything about it, and hunky-dory, everything carries on. But for those few women where it's a problem, I think this is where the focus of attention needs to be drawn. If you look at this slide, we've already talked about irregular periods, and this happens because some months your ovaries do not release an egg, but the lining of the womb is still thickened in preparation, thinking you're going to get pregnant. And if it doesn't then get a pregnancy, it sheds. But with erratic cycles, the buildup of the lining can cause you to bleed for prolonged periods or to have gaps in between and to have heavier periods. Things like mood swings, memory loss, fogginess, forgetfulness, anxiety is all as a consequence of the reduction in the hormone levels. So estrogen and progesterone starts to decrease in time, and the constant fluctuation has its affectation on your system. If you imagine that you've got a thermostat in the brain that manages your core temperature, when estrogen levels are fluctuating, this causes hot flushes and night sweats. As a consequence of this, you don't sleep well, you then get tired, you get irritable, you get tearful, you snap at people, and sometimes people have had to leave high-flying jobs for this reason. Body aches and pains are also a manifestation of the lack of estrogen, as is things like vaginal atrophy, which is the loss of estrogen, resulting in dryness and painful sex. Now, in terms of what you can do, it sounds like doom and gloom, but there's a lot of things that you can do to ameliorate these symptoms. Simple self-remedies, avoiding thick clothing, opening windows, using a fan, cold showers, avoiding hot drinks are easy things that you can do. Avoiding smoking and being overweight are also helpful measures. In terms of non-hormonal therapies, there's a lot of things available, and my next slide will show you some of these. Dietary supplements are also useful, and in the Afro-Caribbean society, we suffer less with hot flushes and night sweats, mainly because of our diet, which includes a lot of soya. Things like phytoestrogens in yam are very, very helpful, and is also alluded to the increased fertility in the twins in Afro-Caribbeans. So there are some benefits with our diet. Things like red clover, black cohosh are also things that you can get in herbal shops. Ginseng is also useful. Word of caution here, St. John's wort is something that people use, but I'd say could be potentially dangerous. If you're on blood thinners, this could exaggerate the effects, or you could have catastrophic consequences. So I'd say this is one to possibly avoid. Vitamins are helpful, and there's some suggestion that vitamin E might also help with menopausal symptoms. Another thing that is quite problematic that you can deal with quite easily is vaginal dryness and painful sex. Avoiding the use of soaps and things like bubble baths, which strip the little protective lining left within the vagina, can reduce the incidence of irritation and inflammation. Lubricants and vaginal moisturizers can increase the water content and rehydrate the tissues in the vagina and help with reducing friction burn effect with sexual intercourse, which sometimes leads to avoidance and other consequences. This slide, I hope you can see, has just a few of the remedies which you can get. Over here are simple lubricants. This is called Yeast. This is vaginal moisturizer. This is one that's water-based. This is another one that's oil-based. This is Silk, which is also a vaginal moisturizer and lubricant. Yeast is now available on the NHS, so be empowered to discuss these problems with your practice nurse or the GP. Things like hot flushes, if you want to avoid hormonal therapy, again, you've got things like red clover in a spray, which you can use to cool yourself down if you're getting hot flushes. So these are non-hormonal simple remedies that you can get without too much ado. Now, realistically speaking, the symptoms that manifest is because of the lack of estrogen. So the only real true treatment is replacing estrogen, which your body is no longer producing. Now, this slide amuses me because I've got quite a few friends who I can readily name in each of these seven dwarfs of the menopause. Sometimes you're a combination where you're sweating, which is the hot flushes, lack of sleep is sleepy, forgetfulness is foggy head, and psycho is when you snap or start to cry for minimal of reasons. Now, moving on to the types of hormone replacement, it very much depends on what your symptoms are. If all your difficulties are related to the vagina, then using vaginal pessaries or gel or cream can help to alleviate the symptoms. And you don't need to go on anything systemic, which involve tablets or gel or sprays. If, however, you're getting forgetful, you can't function at work, you're getting distressed, anxious, and worried you might lose your job, then I would suggest that you did contemplate getting some treatment, speaking to your practice nurse, your GP, and if necessary, getting referred up. In terms of the replacement of estrogen, you can have a gel, you can have a spray, a patch, or tablets. I mentioned the Marina Coil before, and I'll bring it back to the discussion now. If you have a uterus, a womb, you need to protect the lining of the womb with progesterone. So it's the protective hormone. Estrogen, with all its good effects, causes a thickening of the endometrium, the womb lining, and over time, this can become abnormal if it's not counteracted with the use of progesterone. So the Marina Coil is useful. If you already have that in place, then all you need is a gel, a spray, a patch, or a tablet to give you your estrogen replacement. If, however, you haven't got a Marina, you can still have a combination of progesterone and estrogen tablets. In the short term, hormone replacement is fantastic at alleviating the vasomotor symptoms, which is things like hot flushes and night sweats, lack of sex drive, Vaginal issues with discomfort and urinary problems, including recurrent water infections, can be relieved with in the short term with HRT. This will be in the form of local therapy. Unless you have systemic symptoms, then you go to the list I mentioned before. In the long term, there are benefits in protecting the bones, so bone health, cardiovascular health, a known reduction in the risk of bowel cancer and a risk in dementia, especially if you have a hysterectomy and you have your ovaries removed before the age of the natural menopause. If you start using HRT just to prevent dementia in later life, it might actually have a detrimental effect. So I wouldn't recommend going on HRT just for the long-term benefits, but if you're needing it in the short term, then you do have the added benefits of the long term. Now, it would be very foolhardy of me not to mention the downsides with HRT. If you all recall, there's been a lot of bad press in the past, and there was a massive decline in the use of HRT about 20 years ago, when there were two big national and international studies that highlighted the risk of breast cancer. It is true that the use of hormones increases the risk of breast cancer, but I'd like to put this into perspective just to give you some clarity. So if you take ladies aged between the ages of 50 and 69 that have never been on HRT, 1 in 16 in the absence of an increased family risk would have breast cancer. So note that number, 1 in 16 will have breast cancer. And this is without HRT. If you happen to go on estrogen-only HRT because you've had a hysterectomy, then an additional 1 in 200 women will get breast cancer. If you have to go on HRT just around the time of the menopause, and I mean you're still having periods, so perimenopausally, and within the first year of the menopause, we tend to give you a combined form of estrogen and progesterone because we want you to have a bleed on a monthly basis initially to control the erratic bleeding, which you complained of in the initial phase of the prescription. In this instance, there'll be an additional 1 in 70 women that develop breast cancer. And then if you've passed the menopause and had no periods for a year or more, we can put you on a combined treatment of progesterone and estrogen where you have no periods, and your risk is an additional 1 in 50. So you can see that in broad perspectives, it's a very small increase in the number of women. If you then use HRT for up to 10 years, you can just double those numbers. A word of note here is previously we thought anybody going on HRT before the age of 50 had no increased risk of breast cancer. We now know that after a year of use of HRT, the risks start to pile. But again, putting it into perspective, it's not huge. The other problem that people are concerned about is the effect of estrogen causing clots in the veins, leading to blocked lungs and sometimes blood clots on the brain. Again, the risk is minimal. Without HRT, about 3 in 1,000 women aged between 50 and 59 will develop a blood clot, and there'll be an additional 4 to 8 cases depending on how old you are. So again, a small risk, and the risk tends to reduce after about 3 months of initiating therapy. What I just say here now is that the bottom line is if you do need hormone replacement, do not be afraid. It will improve your quality of life. We suggest you start it at the lowest dose for the shortest duration of time, and you have a kind of stopgap check from time to time to see if you still need it. There's no prescriptive number of years as to how long you can use HRT. It's for as long as you need it, bearing in mind the risks, which you just have to reconsider from time to time. The good and reassuring thing is after the age of 50, you have mammograms, and you should please do your self-breast examinations. There are a small group of people who have a mutation that increases the risk of breast cancer, so their decision to go on HRT would have to be done at a specialist level. So not necessarily everybody will be eligible. Now, I think that would be a good point to kind of stop about the menopause, just to remind you that the menopause is a changing time in life with challenges, but you can make choices to improve your quality of life. Now, beyond the menopause, this is after with the withdrawal of estrogen over a number of years, you can then develop pelvic floor problems. This ranges from sexual dysfunction, which could have started before the menopause and through the menopause, but could worsen without any therapy. Pelvic organ prolapse and urinary incontinence are also things that come to the fore. And the reason why is the pelvic floor is very heavily supported by estrogen. So with the gradual withdrawal of estrogen, the supports get weakened, and this is compounded by childbirth and the other ramifications that happen with aging. So if you imagine that the pelvic floor is like a hammock or a basin that's got 3 holes, one through which the water pipe connected to the bladder goes through, one through which the uterus comes through, and the rectum. And this has a band of muscles that help to control your bladder and your bowels so that when you're straining, lifting, you're not leaking urine and defecating all around the place. In addition, the pelvic floor muscles contract and enhance sexual response with orgasm during sexual intercourse. So the lack of this sometimes is one of the reasons why people develop sexual dysfunction. I've already touched upon menopause as being the main cause for pelvic floor problems, but a family predisposition in terms of having weak collagen, people with Marfan syndrome, hypermobility, people able to do the splits at the age of 60, that's an increased risk because your collagen is somewhat deficient and increases your risk. One advantage of the Black race is we've got plenty of collagen, and therefore our risk of pelvic organ prolapse is a lot less compared to Asians and Caucasians. The trade-off is we're heavier, we have the benefit of lack of stretch marks because of good collagen, but we are then heavy boned and can't swim. There are not very many swimming champions, though this is changing with technology. Childbirth and pregnancy, the pressures on the pelvic floor with carrying the pregnancy, and then the effect of deliveries, either naturally with shearing and tearing of the ligaments or pulled out babies with forceps, damage the pelvic floor. Cesarean sections and hysterectomies also cause problems. If you smoke, if you're obese, and if you have a lot of exertive physical therapy, or lifting heavy weights, these can increase your risk of pelvic organ prolapse. Now, Mrs. P is 54. She's now manifesting the ramifications of the lack of estrogen over time. Walking her dog, she can't hang on. She's wetting herself before she gets back. She gets front door latch syndrome, putting the key in the door and dancing, trying to get through to the bathroom. She's also noticed a bulge in the vagina when she was showering, and sex is now becoming uncomfortable. These are the classic symptoms of somebody who's perimenopausal, or I beg your pardon, postmenopausal with a lack of estrogen. Now, just a few facts to make sure that you're still with me and to see if you can sort of relate to any of this. It's very common to have sexual dysfunction. It's a very common cause of marital disharmony. It's the unspoken taboo, and it increases, as I've explained, with advancing age because of the menopause. Very few women seek help, and this is why we're having these kind of health awareness tutorials to let you know that there's help out there and you shouldn't be embarrassed because it's a natural process and we need to embrace this. Female sexual dysfunction is anything from painful sex, lack of libido, and so long as it's causing distress, it's something that we can do something about. So please come and talk to a gynecologist. In terms of what you can do to yourself, anything that helps you to relax, and avoiding stress, sometimes needing vaginal dilators if the vagina is shrunken because of lack of use, using lubricants as we alluded to earlier. Local estrogen is helpful. If you've got loss of libido and tiredness, then we can use testosterone. This is in the form of a gel, not licensed for use in females, but on an individual basis, we can use this to increase libido, and it's got very, very good effects and success. If women have suffered with sexual abuse, in childhood, or they've had difficult examinations at the time of smear tests, or people have been very insensitive about describing the genitals in the past, sometimes this becomes a problem in later years when you're feeling less self-esteem, and sometimes this becomes a problem. On occasions, psychosexual counseling, just to kind of rejuvenate the marriage, might be helpful, and putting extra effort in. And this is where the men come into the equation. Please be very understanding. It's a very difficult time for women. And I think educating yourself and doing your bit to try and help is very important. Sometimes surgery to rectify scarring at the entrance to the vagina might be helpful. If there's splitting of the skin due to thinness because of the lack of estrogen, then minor procedures can be done to widen the entrance to the vagina. But word of caution, sometimes you get scar tissue that can cause more problems. So it's best to avoid surgery if at all possible. So when we speak to ladies in the gynae clinic, especially the urogynecology clinic, we ask about urinary problems, we ask about sexual dysfunction, because many people do not voice this, and then we talk about organ prolapse. A lot of women come because they can feel a bulge, feel like they're sitting on a golf ball, and that's the reason why they get referred, but actually they've got sexual problems and they've got problems with leakage, but they don't tend to mention these. So one thing is, please be empowered to voice these concerns so you can be treated in an appropriate manner. Now, this is what happens when you've got damage to the pelvic floor. As you can see, the supports to the uterus have snapped here, and this is somebody's cervix protruding through the vagina. You can imagine how uncomfortable that would be walking around, trying to have intercourse, but that would be impossible. And sometimes difficulties passing urine or opening your bowels can be the presenting symptom. About 1 in 11 women will suffer with pelvic organ prolapse, depending on how many children they've had, the lifestyle, family history, but only about 1 in 8 see this as a problem. It tends to be people go for a smear test and the nurse says, "Oh, Mrs. Jones, do you know you've got a prolapse?" And then suddenly you become aware of it, and then you start to worry, you do not do anything about it. It's worth going to see a gynecologist, even if it's just for reassurance, to give you some self-remedies that you can do to kind of contain things. In terms of needing surgery, the success is about 2 out of 3 women are absolutely fine, but 1 in 3 might need repeat surgery because the intrinsic problem is the damage to the pelvic floor, which has already happened. And we can only try to rectify something that's cracked. I would assume you imagine you've got a wall with cracks, and if you fill it through with filling before you paint again, the cracks come through again. And that's exactly what happens with pelvic floor surgery. Again, I've mentioned the problems that you can get as a presenting symptom for a prolapse. Sometimes you dribble, you don't empty your bladder completely, you get water infections. Sometimes you have to push on the vaginal walls to empty bowels, and sometimes you have to actually manually evacuate the bowels if you're really struggling. And again, sexual dysfunction could be a presentation. In terms of what you can do, lifestyle changes, making sure you're not overweight, drinking plenty, avoiding smoking are all helpful things. Pelvic floor muscle, pelvic floor muscles, pelvic floor muscles. I say that 3 times. You're told to do them after childbirth. Most people don't, but it's something that's quite helpful and useful with urinary symptoms and prolapse symptoms after the menopause. In terms of how you do this, I would explain in the next slide or 2. Vaginal pessaries are easy things that we can use to support prolapses, and you don't necessarily need surgery. This is a ring pessary which you can use and insert in a clinic. You can take them out to have intercourse, or you could have intercourse with them in situ. There are some that look like sponges. There's this one with a pump. These are sorts that you use in ladies who are not sexually active. So if this doesn't work and you're not wanting to stop having sex, then we need to talk about surgical intervention. It doesn't have to be major. We can just fix the walls that are drooping, and that's called a pelvic floor repair. A vaginal hysterectomy might be helpful along the way, but we can do supportive surgery to hold the uterus in place and actually correct the prolapse. And if you're old, not fit for surgery, on occasions we close the vagina off with very good effect, but clearly you can't have sexual intercourse. So that's only useful in a select group of women. These operations are detailed and discussed when you go to the hospital to see a urogynecologist. They've got good success, and I'd like to add in here that we do not use mesh for the majority of these procedures. Mesh has had a lot of bad press for management of prolapse, and there was a global ban in the UK in about 2018 for the use of mesh for prolapse and incontinence surgery. They did work, but they'd had a lot of complications, especially with prolapse. So at the moment, you can only use these mesh treatments in very limited number of women when every other mechanism or method has failed. Now moving on to incontinence. This is very common, even right from being somebody carrying a pregnancy through to delivery. About 1 in 3 women would leak around that time. Pelvic floor exercises will help, but after the menopause, these symptoms get worse. It's the commonest reason why poor ladies get dumped in nursing homes in the UK. And again, it takes a long time and courage for people to present. My patients classically will say to me, I went to a party, I was dancing, next thing there was water on the floor, I emptied my bladder, and then I thought I can't live like this. If that resonates with you, please seek help. This slide is just to tell you the effects of how urinary incontinence can actually affect every aspect of somebody's quality of life. So it's big, it's a huge cause of distress and even depression. So please, please, please seek help. Now, in terms of types of stress incontinence, stress is the commonest one and about 50% of women. And it basically means you leak because the support mechanism around the bladder is not working. So you cough, you sneeze, you dribble. You can't jump on the trampoline with grandchildren anymore, or you have to wear panty liners. It's fine, we can do something about it. The other type is urge incontinence, where your bladder just won't hold and you just have to dash to the bathroom. And if there's somebody in there, well, God help you. Now, if you feel the bathroom is controlling your life, please speak up and take back control. Please, please do this. In terms of what you can do, I mentioned about pelvic floor exercises. Now, they're very helpful and avoid surgery in about 7 out of 10 women if you do it religiously and in the proper manner. How do you know you're doing the right thing? Because a lot of people do it badly and have done it forever and done it badly. They tell patients in clinic to do a pelvic floor squeeze and they're straining and pushing down, when rather you should be holding in your pelvic floor muscles. An easy way, it sounds crude and horrible, but the best way is to stick a finger in your vagina and see whether you can squeeze on that finger and still talk and breathe at the same time. And that means you've identified your pelvic floor muscles. If there's no tone or you can't feel anything when you squeeze, then you might have a weak pelvic floor, and seeing a physiotherapist to give you targeted exercises and sometimes pelvic electric stimulation might be helpful, and avoid the need for any further intervention. So this is just an animation of a pelvic floor squeeze. So it does work, and like I mentioned, very effective. But like with any exercise, if you don't maintain it, things just relapse. When you come to the hospital, there are easy day case procedures that we can also use to treat stress incontinence. And this is done in the outpatient setting under local anesthetic. And essentially, this is this opening to the bladder. And what we do is just plumb this up to reduce the aperture so that when you cough and sneeze, there's a bulk there that reduces your leakage. And it's successful in about 80 to 90% of women. And this can be repeated. And like I said, under local, you walk in and you bounce out, skipping away, no longer needing to wear tunnel ladies or pads. This is an example of the tape that we used to support the bladder, which I've said we don't necessarily do anymore, but again, was very successful and was a day procedure. And this is just supporting the water pipe. Again, it's still available if every other mechanism fails, but it's not the first port of call now. There are more complex operations, but I don't think they're relevant to today's talk. With regards to urge, avoiding spicy foods, weight loss, drinking at least 1.5 to 2 liters of fluid, and avoiding just listening to your bladder and going on demand. You produce about 30 mils of urine an hour, so therefore holding on for a couple of hours will help to retrain and stretch your bladder. And ideally, you shouldn't need to go more than 8 times during the course of the day, and maybe once at night until you get to the age of about 70, which if you go more than once is not too bad, because as you get older, you produce more urine at night. Another thing is to avoid caffeinated drinks late at night, because this is a diuretic and keeps you up all night. We can give you tablets which help to relax the bladder muscle so that you hold more urine and then you go less often and you leak less. The snag with these is they have side effects, and if you don't drink enough water because they work on other systems in the body, you can get dry eyes, which is not very comfortable in elder ladies. You can end up getting constipated, which is another problem, which could aggravate urinary symptoms. So you need to drink plenty, but if the symptoms are still disturbing with the side effects, then there are other medications like mirabegron, which doesn't cause the side effects with the mouth, but you have to have very well controlled blood pressure because you could have side effects and affectation with blood pressure. So it's important that you have good blood pressure control for some of the other medications that we use. And again, we have some simple measures. Botox is not just used for wrinkles, it's also used in the bladder, it's used for headaches. And the way it works is we inject little droplets into the bladder to kind of paralyze the bladder muscle. So again, just like the medication, it helps to expand the bladder and you're able to hold more and leak less. And this again, we can do in the outpatient setting under local anesthetic with very good effect. And I'm going to stop now and just tell you to remember to squeeze your pelvic floor and hopefully realize that you can do a lot for yourself. So just to summarize, erratic periods before the menopause, we can manage. The menopause itself, we can do plenty, new lease of life. And just take this last take-home message. Menopause, you can see it as a challenge, but I would see it as a change and a new chapter in life. You have choices, pick your choices and enjoy your life to the fullest. Thank you very much.
Thank you very much. Thank you very much, Bim. If you stop sharing your screen, we've had lots of questions. Some have been sent to me. Thank you so much. That was excellent.
Thank you.
It's the first time I'm not envious anymore of those that can do the splits. Because I used to look
exactly.
But now I think that's all right then. Yeah. Okay, so I'm going to start with some of the questions in the chat. Some people have sent me private questions, and please do, if you want to send me any private questions to bring up if you want to do that. So one of the first questions was, how many days should you bleed without being concerned?
So up to 7 is kind of all right. Most people bleed between about 5, but if you're bleeding for more than 7 and they're heavy, then at least have a conversation. But if it's disturbing your quality of life, even if it's 5 days and it's very heavy or painful, you still seek help.
Okay. One of the questions that if you have a young girl who starts her periods early, does that mean that she will start the menopause early?
Potentially, because you got your bag of eggs, okay? And so long as you deplete the eggs in your basket, then yes, you're more likely to. So the sooner you start, you're kind of losing eggs quicker. And once your eggs are finished, then you would probably go through the menopause, maybe about a year or two earlier than the average of 51, which is why anytime from 45 to 55 is kind of the age span, because it just depends on how much you have. And there are some conditions that cause more rapid depletion of your ovarian reserves. So that might speed things up. And if you've had surgery because of ovarian cysts, endometriomas, those kind of things can reduce your egg reserves as well. So those factors need to be taken into cognizance as well.
You know, you talked about the pelvic floor exercises. When can you start, if you've had a baby, when can you start doing pelvic floor exercises?
So really, you should start them before you have the baby. Yes, so prenatally, you should start them. And a lot of antenatal classes give talks and sessions on antenatal pelvic floor training. So you start them beforehand, so you strengthen and enhance the pelvic floor before delivery. And then postpartum, you start when you're comfortable. Because if you've had an episiotomy or you've had a forceps delivery, you'll feel very swollen and sore. So for the first few weeks, you won't be able to. But once you feel comfortable, then you start them from then on. And ideally, you should be religious and do them as often as you can. I forgot to mention actually in the talk, there are some apps that you can get off the Android and Apple store. There's one called Squeezy, which is something that reminds you as to how often you should do them. So there's like a little reminder on your phone and you think, well, I must do them now. You can do them anywhere, even at the bus stop, at traffic lights. So long as you're doing the right thing, you can function and do other things at the same time. So it doesn't have to be a kind of sit down, focus. It doesn't have to be a chore. You could do it anytime, and it shouldn't impinge on your quality of life in any other way.
Okay. There's a question here about cesarean section is supposed to keep you honeymoon fresh. How come, after you mentioned that after having cesarean section, that you can still have all these problems?
Because it's not just the operation. You've got pregnant, yeah? So the pregnancy in itself is compressing on your pelvic floor, yeah? Even an elective section. Yes, there's some suggestion that if you have a cesarean section before 8 centimeters of dilatation, it might reduce your risk of pelvic floor dysfunction. But the reason why you get it is cutting through things, you're affecting the nerves. So you have not just nerve damage, you have muscle damage with childbirth. So cesareans cause nerve damage. So if you have a neuropathy, which is nerve damage, it reduces the strength of the pelvic floor. So over time, you can still develop symptoms. And if you remember, if you've got excess collagen flexibility, you've already got that risk as well. So even if you've had a cesarean, it doesn't mean you won't get those symptoms because you already had your family predisposition.
Okay. Someone's asked, the age at which you get menopause, is that genetic? Is it possible to become menopausal before the age of 40?
Yes, it is. Yes, it is. But that will be classed as very, very premature. So sometimes if you have deficiencies with your genetic makeup. So as females, we have 2 X chromosomes. Yes, in things like Turner syndrome, you have 1 missing chromosome. So you already have a reduction in the amount of kind of eggs that you have in that regard. So you're at higher risk of losing your eggs sooner. You can also end up with an earlier menopause if you've had surgery where you've had your ovaries removed, or you've had radiotherapy and they haven't shielded the ovaries, or you've had chemotherapy. So other things like medication can also put you through an earlier menopause. And there is some people with a familial incidence of premature menopause or premature ovarian insufficiency, as we call it.
Okay. Got Jenny with a question. With a hand up. You want to ask a question, Jenny? Go ahead.
Yes, thank you for that presentation, Bim. It was really, really excellent.
Thank you very much.
I had fibroids, which I didn't realise until my blood went down to 1% and I was still walking around.
Whoa.
And I think I got through only by faith because I don't take blood transfusions. But what I wanted to ask was, I was put on detrusitol, which is a tablet that helps strengthen the detrusor muscle. And I think that the years that I've been on it, it became ineffective, basically.
Yeah.
And what I noticed was I was leaking even more. So for me, what I did do was, or what I did notice was that I lost 2 stone, and I started doing the pelvic floor, which I found hard to do sometimes, but I know you said you can do them anywhere. But I kind of like got a bit disheartened with it, because also that I had this tablet that I thought was going to really give me some time to just do what I needed to do rather than focus on doing the pelvic floor exercises, which I know is still beneficial, because I started doing the I think you call them squats. And
correct,
what I
yeah.
was when I did the squats, I did the squat challenge, you did 50 and then add 1 every morning. And that kind of helped. And I know that I do have stress incontinence, and I think that since I started taking this Protandim, which is a herbal kind of supplement, it's become less and less. So what I wanted to ask was, do I still need to actually have a tablet? Because I think they wanted to put me on something different, because I was still leaking a little, not as much. And what I've noticed I've been able to do was walk for an hour and a half, not focus on the fact that I've got to walk to the nearest toilet, which is where I was before. And that's been something that I've noticed. And also the menopause, because I had embolization of the
fibroids,
that brought the menopause on. And I think that what I noticed when I didn't take this Protandim was that I was still sweating cobs and everything, but it was something that I didn't notice. But since I've been taking them, somebody said that, oh, you're not fanning anymore. Why? And I was like, well, I don't know. And I could only put it down to this Protandim that I'm taking. But like I said, it's kind of given me that peace of mind that I can actually walk now to wherever and not focus on the toilet, which was like my daily thought. You know, I couldn't go here, couldn't go there, because I had to know that there was a toilet within reach. You know? So for me, that's been massive. But what you've given today is really, really something that I really will value. So thank you very much for that.
Oh, thank you. Now then, I just want to ask you a question. Did they have you changed your drinking habits, and do you drink optimal?
I drink 2 litres of water every morning. Good. And
every morning.
Every morning, yeah. That's my regime. I tell everybody to drink warm water every morning before they brush their teeth, because that will just flush out all the toxins and everything.
Yeah, but you can never drink though, and end up on the loo all the time.
I know, and I was going to say that, but because I'm a woman, I know you're supposed to drink 2 litres. And what I've noticed as well, I've reduced my coffee, but I mean, I've had one.
Exactly.
That's my treat, one a day, you know.
Water.
Coffee lover.
Water.
But, oh yeah, I've had my water. I've had my 2 litres. But yeah, so during the day, after I've had my coffee, I do drink warm water throughout the day. And I found that's more beneficial. And, you know, my worry was, being 60, I'm going to get worse with this, you know, leakage, but it hasn't worsened. And that was something I was conscious of when I made the decision to drink 2 litres of water a day. I was like, oh, I can't do that because I won't be able to go anywhere. I've got to be at home. But what I've noticed is I can drink it and I feel, you know, okay.
Better in yourself.
And I've actually focused the fact that if I walk to the shops, which could be like 20 minutes, I do go to the toilet before I leave, but then I could also need it before I get to the shops. But I've been consciously doing my pelvic floor when I've been stood still. And I know that that helps, because I know that when I had the tests done at the hospital, they said that if I find that I need to go straight away, I need to go. But they said if you stand still and do your pelvic floor muscles, that will help. Exactly. And what I did was, I didn't trust that process.
It works.
I tried it at home and it works.
Exactly.
It absolutely works. So, you know, I was grateful for that, because like I said, I could get to the shop and back and I was great. Yeah.
It's actually nice to hear somebody give that testimony that it works. That's brilliant. Thanks, Jenny.
It does. Thank you.
Thank you. I'll just move on. There's another question here about, if you've had a Marina coil that's been in place for over 15 years as a form of contraceptive, could that mask the menopause?
No, because if you've had it for 15 years, it's time expired. So there's 52 milligrams of the hormone, okay?
You've had it less than recently for 15 years, so maybe not straight on, but had it continue. I think you mentioned.
Oh, right. Oh, sorry, I beg your pardon. Yeah.
So if you take it, I think you said that you have it for a period, then you should change it.
Yes.
So I think what they're saying here is that they've had it for a period of 15 years, but obviously there's the rules of changing it intermittently.
I understand now. Okay, so every 5 years before the age of 45, after 45, it can last for 7. The thing about the Marina, all it does is it suppresses the lining. So you either get light periods or no periods at all. If you are lucky, which is 75% of women, you might just transit and not know anything about it. And apart from having blood tests, you won't know you've gone through the menopause. But from what I've already discussed and explained, you would have other symptoms that will give you some guidance as to whether you should suspect that you go through the menopause. So hot flushes, night sweats, not sleeping well, all those other things. So the absence of the period side is because you've got the Marina, but if you've got the other manifestations that you're going through and you have those symptoms and you then need the remedies, and then you might need to go on estrogen if your symptoms are not managed by the self-help things we talked about.
So in essence, menopause, the major manifestation is the absence of periods.
Yes.
So if you either had anything at all that stops you from having periods, you might not know when you enter the sort of hormonal menopause, because you don't have that signal that's told you that your periods have stopped. But your body should still have all those symptoms that you've talked about.
Correct.
Yeah. And so you need to seek help if you're having any of those things, like
exactly, yeah.
The sexual dysfunction, the grumpy. I'm one of your friends now. I don't want to know which one I am. Without that, seven dwarfs.
The 7 dwarfs of the menopause. It could be a combo.
Yeah. Lovely. Okay. So someone's asked, will menopause reduce the size of fibroids?
Yes. So fibroids are fed by estrogen and progesterone, but mainly estrogen. And so that's usually the classic thing is we say, well, when you get to the menopause, your fibroids will stop growing, which is true. But if we're now telling you to go on HRT, then the fibroids will keep growing or stay the same because you're still feeding them. So yes, the ready and straight answer is yes, fibroids shrink after the menopause without hormone replacement.
Okay. So I think the other thing that I know that comes up, and some people have sent me some questions about this, about the HRT, is the real concern about cancers and
Yes.
HRT. And I know you've described the risk. Are there things that you've talked about, some of the things that you can do without having to resort to HRT?
Mm-hmm.
Could you just explain which ones you would think are sort of the best before you went to HRT? So some of those other things, and do you know the pessaries and the gels, do they have the same risk because they're hormonal?
Right. So maybe I didn't make it clear in the presentation. I do apologize for that. So local estrogen, vaginal estrogen, either the pessary or the gel. The pessaries have got 10 micrograms, which is a minuscule amount. So 1/100th of a milligram of estrogen. So very, very low dose. And what you do is you use one pessary every night for a couple of weeks and then twice a week to maintain. And the cream is an applicator, and you pull a plunger full and squirt that in the same method every night for 2 weeks and then twice weekly, releasing about the same amount. So it's a very minuscule amount, which is local to the vagina and the bladder area with no systemic effects. So there's no increased risk of anything to do with the breast. So if your symptoms are solely genital, sexual dysfunction, then you can just use local estrogen with no fear or concern about your breasts. We even give those treatments to ladies who've had breast cancer, who are struggling with the menopause. So it's very, very safe in that regard. So it's got no risks with the breasts. Okay.
There's also a perception, and I don't know whether you've seen this in your clinical practice, that Black women don't have menopausal symptoms. Is it that we just get on with it, or that truly we're not as prone to hot flushes and some of the menopausal symptoms as our white counterparts?
It's true to a point. And the reason is our diet. Yeah, because we eat a lot of beans, so soya, flax seeds, yam tubers, got estrogen, phytogen containing things. So because of our diet giving us some of these estrogen similarly kind of broken down preparations, it does help. Okay. And I suppose we have this, I'll carry on with life. We're more resilient, I guess, in a way. And you kind of see your grandma went through, and you just assume, well, you might think you're getting on with it. But actually, if you ask people, they say, oh, she's a bit grumpy, she's a bit snappy. And you might not perceive it because it's not causing you direct problems. So I would say, yes, we manage better because we have our diet that helps. But actually, it's a perception that we're managing better. And if you actually ask people, because it's what you don't see. Other people might think, oh, what's the matter with this one? Is she menopausal now because she's always grumpy, she's always snapping, she's short with us, or she's crying at everything I say. Or hypersensitivity, all those kind of things are subtle signs that you think you're coping, but actually other people might not be able to tell you, which is why if you know now what the signs are, you've got friends who say, well, actually, Bim, what's on with you now? You seem to just snap at everything. You better go check your hormones or get some HRT. And that's the laughing joke amongst my group of friends now. So all these things about the different remedies is what we talk about now. And people should embrace it and not be embarrassed about it, because you can't do anything about that stage of life. You just need to embrace it and get on with it, but seek help.
Okay. One of the other concerns was that with the problems with the incontinence, the natural inclination is to want to drink less.
Exactly. Yes.
But you said to drink more.
Yes. It's the logical thing that you think the less you drink, the more you produce. But actually, your body has to absorb a certain amount of water for its bodily functions. So if you don't drink optimal amounts, or you drink wrong drinks like caffeinated drinks, a lot of alcohol, which are diuretics. So coffee, tea have got a lot of caffeine. Now I'll tell you, green tea is the worst of them all. So you think you're washing out your system, it's because it's a diuretic. So you're releasing all the fluid, but it's very irritant to the bladder because it's more acidic than normal urine should be. If your urine smells, if it's colored like beer, then it's too concentrated, you need to drink more. So the more you drink, the more dilute, and the closer to clear water running through a tap that your urine is, the better for you. So if you drink less, you've got concentrated urine that's irritating to the bladder, and the bladder's just doing that all the time. And it's twitching, you can't hold on, because it's like putting salt on the sore or acid on the sore. You can understand how horrible that feels. And that's exactly how the bladder feels. So that's why you end up going more often and leaking before you get there.
Okay. There's a number of questions about fibroids. So one is any tips about how you'd manage, and one was anything you can do to reduce the size of fibroids pre-menopause without surgery? Because people always reluctant to have surgery. So
everything you do is only going to be transient, isn't it? Because you're suppressing the hormones. So if we give injections that shrink the fibroids, they'll shrink, but as soon as you stop, they rebound and they grow back. Sometimes if you're kind of like around 49 and you go on the injections, then if you're lucky and they shrink the fibroids, you then transit into the menopause, then they've shrunk them, but you've got no reboost of your own system to then cause regeneration of the fibroids. But if you're not menopausal, they'll grow back again. So other than surgery to remove the uterus or to remove the fibroids, and if you're near the menopause, then it means it's more sensible to have a hysterectomy rather than removing the fibroids, because it just seems logical that you're reducing your risk of anything else going wrong. Then I would say, unfortunately, there's not very much you can do. And sometimes you have to actually do hysterectomies for ladies after the menopause if they've got big fibroids and they want to go on HRT. Because like we said, if they're getting symptoms because of pressure from the fibroids still being quite large, then you take out the uterus and they just go on estrogen-only HRT. So you reduce your risks of things like breast cancer, but you've had to have a trade-off with a major operation.
Okay. Someone's asked, if your urine is really clear, like water, is that a good thing?
Say that again, sorry, I missed that.
If your urine is as clear as water, is that good?
It is good. It means you're drinking good. It means you're drinking a good amount, yes.
Okay. And someone's asked about contraception to use over the age of 45.
So that is a very, very kind of broad question, because it needs to take into cognizance whether you're overweight, whether you smoke, whether you got migraines and that sort of thing. But in general, if you're slim, you've got no risk factors for thrombosis or anything of that nature, no family history of heart attacks or strokes, you can carry on with your HRT, your normal contraceptive pill till the age of the menopause. Gone are the days where people after the age of 35 will bring everybody around and say, because you're over a certain age, you need to swap from the combined pill to the mini pill. It's not necessarily the case. If you've got no additional risk factors, in terms of risk and benefits, you can carry on through to the menopause with your normal combined pill. You can opt to go on the mini pill if you feel safer and carry that through to the menopause. Or you could have something like the hormonal coil, the Marina coil, and use that as your contraceptive method. So unless you've got the added risks, you can carry on with estrogen till the menopause. So smoking, obesity, family history of thrombosis, and cardiac conditions will be the ones which would indicate taking you off the estrogen, because it increases your risks. Yeah.
It's 12. Are you good to stay for another 10, 15 minutes?
Absolutely. I'll stay for as long as you want me.
Thank you.
Long as you need me.
There's a number of questions about the 10 years about carry on the HRT. So for everybody, you get to a point that even if you did nothing, you finally stop having the symptoms, I suppose.
Yes. So the most bothersome symptoms for the majority of people, the most embarrassing, is hot flushes. Luckily, because we're dark skinned, it's not that obvious, but you feel warm. Yeah. In a Caucasian, you can see the whole red flush and everything else, which then causes more embarrassment and it gets worse. So the majority of people, hot flushes is the main thing. Yeah. Within a couple of years of the menopause, it starts to ease. But it's about 30% of women that even in their 70s still have hot flushes.
But that means that if you're on HRT and you presented those symptoms, a point should come where you stop because you shouldn't have any more symptoms. Or are you just delaying the onset of these symptoms?
No, not necessarily. I would say that essentially you should have a revisit every few years. So if, for example, I'm 52 now, say if I went on HRT now, I'd say by 5 years, it's worth, because you're still working, it's worth having a kind of revisit, saying, well, okay, do I still need this? You wean yourself off or you come off. You see how you are. And if you're absolutely fine, you think, well, I don't need this anymore. If your symptoms come back, then you start again. You can do that stop, start at intervals. And after 55, you might say, well, every 2 years, I'll see what I'm doing. And then have a stop, start approach. And if you're fine, you don't need to go back on. I've got a 79-year-old lady who has 5 horses and swears by HRT. And if you stop it, she says she'll die the next day.
There's a concern about fibroid surgery in the UK because fibroids are not something that affects white women. And so there's a concern that, they're not as good at doing fibroid surgery in the UK.
Right, okay. So in Manchester, they're extremely lucky. You have Eddie Osage, okay? So just go to Eddie. He'll sort you out. Fibroids, endometriosis, he's the man. Anything laparoscopic, remove anything, keyhole. So the concept that people didn't know how to manage fibroids, yes, it was true that before the influx of Afro-Caribbeans into the medical gynecology setting, it wasn't something that was seen very readily. So that if you had surgery for fibroids, there was always that risk that you might end up with a hysterectomy. Like Eddie said, the risk is extremely low now because of the techniques and the expertise of the people that do it. So the key thing is you go to people that do a lot of it, okay? And in every hospital and in every region, you have experts that deal with fibroids. So you know your own limitations. And if you feel you can't handle it, you hand it on to somebody that can do the surgery. So fear not. I would say there's so many people of African descent that are doing a lot of good surgery, but we're very, very lucky that down the road from you all, you have an expert. So I would say it used to be the case. And I see the person that's asked the question is a GP who I know very well. And yes, I know exactly where you're coming from. In every unit now, you have somebody that can do them. And if they can't, then patients tend to do their own homework now anyway and say, I want to be referred to this place because I know this person can do the surgery for me. So don't let that be a deterrent to come up to the hospital.
Thank you. And I did not plant that question, you know.
I know you didn't. I can see it in the chat box. Yeah.
Can someone who has got to the menopause have IVF?
Whoa. Well, by definition, you've gone through the menopause. You haven't got any of your ovarian eggs, any of your own eggs left. I suppose you could have donor eggs. You might think of adopting, but I think certainly it won't be your own eggs, and that would be again something where experts like Eddie will be able to give more detailed advice. But yes, you can, but it won't be your own eggs. So
where we hear of the 59-year-old woman who is now pregnant, it's like that she got pregnant by IVF with donor eggs.
It is most definite, yes.
Okay.
Yeah. Because if you remember, your eggs were there before you were born, okay? And before the menopause, about 10 years before, your fertility rate reduces drastically. So what you have left in the basket is the bad eggs, okay? So after the age of 40, you get pregnant, there's a 1 in 2 chance of a miscarriage because of chromosomal problems, because of the bad eggs. So if you get to 59, there's no eggs left anyway. And if they're there, they're rubbish. So you're not going to get pregnant until you have a monster. So therefore, you'll be using donor eggs to get success anyway in the first place and even achieve a normal pregnancy. Yeah.
Okay. I've got a direct question that says, I've got a Marina coil to reduce heavy bleeding, and then I became menopausal. And it was due to be changed last year, but now because of COVID, we got it changed. Is it still safe, or do I need to be seeking advice ASAP?
How old are we?
How old are we? Just put it in the chat.
Because if you had the coil put in after the age of 45, and if it was for heavy periods and contraception, it works for up to 7 years. And by that time, if you're not bleeding, 53. Then you can imply that you haven't got periods anymore. 53. How old? 53. So you had it fitted after the age of 45, so it'll last 7 years. So you're fine. Okay. So long as you're not using it as part of combination for HRT. If you're using it to protect the lining for HRT, rather than the 7, it's every 4 years you need to change it. And if you've run out, then all you get is tablets to protect you while you're waiting to have the Marina replaced. But in terms of contraception and periods, you're fine.
What can you get over the counter? Do you have to go to doctors for all these things that you talked about
so if you recall,
little sachets, are they over the counter? Are they prescription?
Right. So can I, shall I go back to my presentation or shall I just talk? Which one?
You mean the ones that you showed on the table?
Yeah.
Yeah, if you can find that slide and just share and so that people can see.
Okay. Oh, hang on. Oof. Sorry, give me 2 seconds.
That one.
That one, yeah. So these, yes, Vagina Moisturizer, water-based, oil-based. You can get them on the NHS on prescription, so ask your doctor, yeah? This is silk, and that's the box. That's another one. You can get that online or supermarkets. Just talk to the pharmacist. Many pharmacists have got their own brand of these things, but these are good ones. This is a spray. and it contains red clover. Yeah, and this is tablets, and it contains red clover as well. So this is a spray. Oh, I've got a canister somewhere. You just kind of flick it around. I've got samples. I've got a whole bag of Vaginal Moisturizer. So come visit me. And I've got display boxes of things like that. So yes, they're available. And if you see on here, on this one, it says NHS, okay? And I've got leaflets about it as well. So you can definitely get those, you know, through the GP over the counter. But hormonal, you need a proper kind of assessment, because you need to make sure there's no problems. And if you're going on any of these things, estrogen, vaginally, that kind of thing, you need to be up to date with your smears. And then the other final thing to reassure you is that your risk of getting breast cancer from HRT, yeah, is less than your risk from being overweight and smoking and consuming alcohol. So put it into perspective that way as well. That's one thing I forgot to mention. Yeah. So again, it gives you that reassurance that if you need it, don't be frightened.
I think we're just saying just before we joined that we're looking forward to going back to face-to-face. Now, you see, if this was face-to-face, we'd have all helped ourselves with some free samples.
Absolutely. Yeah. I can get them across somewhere. There we go. There's a bit back.
I've got another question here. A 40-year-old lady who has regular periods every month, but a couple of weeks before her period starts, she starts to have anxiety symptoms like shortness of breath and breathing difficulties and feeling lethargic and feeling hungry, especially for carbs. I can identify with the carbs bit. And it makes her IBS worse. And then she's also noticed that her periods are really heavy for the first 3 days, and then it slowly reduces. She's just asking, are these symptoms of menopause? Because she gets sleep deprived, she's hot flushes, she's got a burning sensation in her urine, sweating at night, and loss of libido. So she's only 40 though.
And is this around her periods or in general?
It starts just before her periods. If I've got that wrong, just let me know in the chat. But this is what I'm reading, that a couple of weeks before her periods, she says.
And then when the periods happen, does all the symptoms subside?
I suppose it says it says period heavy for the first 3 days, and she has sleep deprivation, hot flushes. Let's see, she's also got started urine infection symptoms 8 months ago. So if
the symptoms are just around the period and they then settle and then come back next month and all that, it's just the fluctuation in the hormones because of the periods, because your periods happen because of the drop in your hormone levels. So you have a peak of release of hormones, and it's the withdrawal of the progesterone that causes your period. So that change can give you these symptoms. But if they disappear and are not there the entire month, then it's just a premenstrual kind of fluctuation in your hormone levels, as opposed to a constant because of a chronic deficiency. Okay,
I hope that's helpful, iPhone. If it's not, just put another question.
But yes, you could go through an early menopause at 40. So if those symptoms are bothersome, and most of the time, it's worth getting checked out. We don't routinely do hormone levels on ladies around the menopause. We go more on symptoms. But if you're having these symptoms less than the age of 40, then sometimes we do some blood tests. But if you're 49 and you're getting symptoms, we just go on your symptoms and give you a trial of therapy rather than doing blood tests. Because so long as you're having regular periods or infrequent periods, you still have something in your ovaries. But if somebody less than 40 has got high hormone levels in the brain, then it shows that the ovaries are on overdrive already, and suggests that you're probably approaching that endpoint sooner than usual.
So Nafisa has clarified that it's a couple of weeks before, and that she's also on antidepressants.
Right, okay. Fine. So I think the combination, sometimes those symptoms might have been worsened, but the antidepressants do help to suppress some of the symptoms, which is under the spectrum of premenstrual syndrome, or we call it premenstrual dysmorphic disease. So you can have those symptoms, and it's because of the changing levels of hormones. But there are certain times where you might need to do things like have something like the hormonal coil, the Marina coil, and then you might have to have estrogen by gel or patch, so you have a constant sort of release of hormones, so you're not fluxing through the month, and that might help some of the symptoms that the antidepressants are helping with. So you don't having that constant kind of change in mood and everything else. So it's not the menopause, but it's still a hormonal kind of fluctuation in a different kind of manner that can be managed with a similar kind of combination.
Okay. This is not directly related to menopause, but it's about periods, really. Someone's asked, is it normal to have yeast infections monthly just before your period?
Yes, unfortunately, some people are more prone to them around that time, and some people are more prone to bacterial vaginosis again around that time. What would need to be done is sometimes you need a kind of long course of treatment to try and clear your whole system of the yeast infection. Because just using vaginal pessaries, you're just kind of clearing the exit point, but actually you can have yeast infection right through your mouth, through your gut, all the way through. And so oral tablets are sometimes helpful, but this would need to be under the auspices of a GP or a practitioner, you know, in a sexual health clinic or in a gynae clinic. And you might have to have oral tablets over the course of a few weeks, sometimes months, to kind of sort of help to clear. And if you have a partner who's male, who may not exhibit symptoms, but could be harboring the actual yeast fungi, then they might need the cream as well, just to sort of stop self kind of, passing back and forth between the two of you. And that's helpful as well. And probiotic live yogurt is helpful. You know, you drink that as well. They used to say, put it in the vagina. I'm not so keen on that. Just drink it.
So someone's asked that they've been having sexual dysfunction. How old is it where you just say you'd advise them to just stop having sex?
Well, it's a personal thing. I would say, I don't think there's any age limits. I'm not ageist. I had an 80-year-old lady who came to have a minor procedure to open her vagina a bit wider because her boyfriend, who she was getting married to, was 59. So, you know, she's 80, good on her. You know, so there's no kind of cutoff number. It's you as an individual. Yeah. If you prefer a cup of tea, good for you. But if you want to, then there's nothing stopping you, and seek help. Doesn't matter what age.
Great.
If you don't use it, you lose it, basically. Because what happens is your brain thinks, I don't need to supply that area with much blood supply, and it gets thinner and closes off, essentially. So the more you do it, the more blood supply, the longer it lasts.
Okay.
Yeah.
All right. I hope that was helpful, the direct question. How long does it take for someone to go through the menopause?
It could take a number of years, which is why, you know, people say, oh, I'm going through the menopause. And we actually ask them, so yeah, their periods are getting heavier, they're getting erratic. It could start from 45 and carry on till 50. It could start from 50 and you could carry on till 55. I never kind of give a kind of fixed number now, because always when you do that, you're kind of made a liar of. I had a secretary who's retired recently, and she started with the issues with her periods on 50. She got to 55. I said, oh yeah, at the top end now, you should stop. 57, she still hadn't stopped. I thought, oh my goodness, what am I going to do with this woman? So eventually I had to do an ablation, and that stopped her periods. She had nothing else. It's just she had periods, but it was a bit of a nuisance, you know, going to the supermarket every month, getting pads and tampons. So it's difficult to say exactly, and it's very individual. But you could go on your family history. That sometimes is a clue.
Someone said, but if you don't regularly have sex because of religion, what will happen?
To what? Your vagina?
I haven't asked. They just stop the question there with what will happen.
Right. Okay. So if you don't use it, you lose it.
Yes, to the vagina.
Proper adage.
It's clarified.
Yeah. So infrequent sex causes a quiescent vagina, and you end up with worsening vaginal atrophy, which is a lack of, you know, activity down there. And unfortunately, it's a price you pay, basically, because there's no estrogen. So if you don't do anything, and you're happy with that, then that's fine. But you potentially would have difficulty and be uncomfortable when you do have it if it's infrequent.
I'm 46. I have an implant which is due to expire this year. Is it okay for me to continue with this, or would you suggest another type of contraception? I'm thinking of going for the coil.
You mean the next plan implant, the arm implant?
She hasn't clarified with the arm.
I would imagine it's the arm implant, and if that's the case, yes, if that suited you well and you had no problems with that, then the coil would be an excellent one to have. Yeah.
Implanon.
Yes, Implanon is an implant in the arm. Yes, it's a 3-yearly implant. Yeah, if you didn't have any problems with bleeding or anything and you're happy, then yes, the Marina coil would be a good one to go for. It'll last you 5 years if you're less than 45.
Okay, so I'm going to take 2 more questions. And one is, I have irregular and heavy periods and polycystic ovarian syndrome. I've been advised for Marina coil, but I'd like to get pregnant. is there any other treatment for PCOS? And can I still have a chance to get pregnant at age 35?
Definitely. 35 is the new 21. Yeah. So don't despair.
Very young.
Very young, very, very young. I wouldn't have said that 20 years ago. That was ancient, but now it's very young. So yeah, seriously speaking, polycystic ovaries, yes, the Marina Coil is a silly thing to advise you if you're trying to get pregnant, is the first thing to say, because it's stopping you conceiving, because it's blocking the area where you'd conceive into. With regards to polycystic ovary syndrome, I think optimizing weight is critical. Yeah. And there's something called inofolic alpha. So inofolic, INOFOLIC alpha. And if you just Google that on the internet, it will bring you onto a page called something about infertility.co.uk. And inofolic is a combination of folic acid and some other components. And essentially, inositol is something that helps in the way you break down glucose. So simply put, polycystic ovaries is your ovaries are just holding onto the eggs, not releasing them. So you're not ovulating, you're not getting pregnant because your brain thinks you've ovulated, and the cycle carries on. When you have this situation, you become insensitive to insulin and you're kind of in a pre-diabetic state. So inositol helps with the way you break down glucose and helps to reverse some of your metabolic imbalance and helps with regulating cycles. Is highly recommended by infertility experts. You can't get it on the NHS, but it costs about 30 quid for about 2 sachets a day. And if you take that for about 8 to 12 weeks, weight loss and a lot of other things are improved. And it's non-hormonal, and it's a good way of at least enhancing your chances before you see a specialist. Well, 35, if you've not sought help, go see a specialist now, because like we've mentioned, the longer or the further away you are from your 30s, then obviously your fecundity, which is your real chance of getting pregnant, starts to decline. And it might take, a couple of years as opposed to a year trying. So I'd say seek help now, but inofolic alpha is something that you can easily look up on the internet and purchase in the short term.
Okay. So the last question is just clarification from the lady who's asked about if you don't regularly have sex because of your religion. I think she might be clarifying that she's asking that, does it bring menopause on early?
No. Because menopause is related to your basket of eggs, essentially. So things like, going on the pill, because you're not releasing your eggs, then obviously, your menopause could potentially be delayed because you still have the eggs trapped in there. But having sex or not having sex has no impact on your ovarian reserves. Not at all, no.
Will miscarriage be a result of having polycystic ovaries?
Yes, yeah. You have a higher incidence of miscarriages because there's the feeling that the progesterone, which helps to kind of support the pregnancy in the first few weeks, might be deficient. And so if you've had recurrent miscarriages, and they might have mentioned this last week, sometimes we give progesterone support in the form of vaginal pessaries or tablets, just to help the pregnancy support till about 12 weeks, when the placenta then takes over. So yes, potentially it could be.
Okay, that's a last question is I'll just get it, is someone's asked, where is it now? Yeah, does having an abortion have a negative effect later on in the life of women?
Well, I suppose emotionally, psychologically, potentially can. Yeah, because if, how I mentioned about needing psychosexual counseling, in later years, if the discomfort you encounter is reminding you of the process or the procedure at the time where you had the abortion, if you had it awake, on the local, that kind of thing, then potentially it could affect you in that psychological manner. But in terms of physical down there, then not really, no.
Okay, so I'm going to, Jenny, did you have a question you wanted to ask or a comment?
Well, just in addition to the polycystic ovaries, if you're a vegan or vegetarian, does that have any bearing on it?
Well, I think people say certain diets kind of help with symptoms that you get. And if I recall, Eddie did touch upon some of the things that you can do to kind of improve your diet and improve your kind of state of health with regards to fertility and that sort of thing.
Oh,
So, and I suppose if we say that polycystic ovary syndrome is kind of like a pre-diabetic state, then I suppose avoiding things that would kind of increase your demand for insulin would not be a bad thing to look into. So avoiding carbs. Yeah.
Avoiding carbs.
Yeah. So actually being a vegetarian or vegan might not be a bad thing. It might even be to your favor.
Yeah.
You've got to remember you need your supplements though to make sure you have kind of a well-balanced diet. Yeah.
That's the thought I was having. Thank you very much for that.
You're very welcome. Very welcome.
Thank you so much, Bim. This has been excellent. I have learnt a lot, as I'm sure many people who have tuned in today and who will eventually watch this on YouTube. So thank you so much for this today.
You're very welcome. I'm very much grateful for inviting me, and thanks very much for all the participants and for all the questions. I really enjoyed myself. Thank you.
Thank you.
All right then.
Okay.
Bye everyone.
Before you go, just to say that we're going to continue, obviously, our emphasis on wellness and women's health. And next weekend, we have Dr. Joyce Amer, who's going to talk to us about keeping our skin nice and beautiful. Yeah, so that's a good one to tune into, ladies. So we've looked after our insides, so we're moving outside now. So look forward to that as well. We've also put in the chat a number of sessions that we'll have during the week. So I'm going to hand over to Charles to expand on what's happening during the week.
So Bim, thanks a lot. It's been amazing. I've learned a lot. Yeah.
Good. Pass it on to the boys. Thank you.
It will become very handy for my daughters. So thank you very much. Great. Yeah. So just to say that on Tuesday evening we have another session on the vaccines with Ngozi and other colleagues, and later on joined by the vaccines minister, as well as Professor Kevin Fenton and Bola. But it's great that the whole of this month we've dedicated that to women. For those who are not aware, we have Healthy Hearts sessions on Tuesday evenings. So that's 30 minutes of nutrition. So diet is important, and then 30 minutes of exercise. And the amazing director, is always on hand. I've asked Karen if we could have, some targeted sessions on the pelvic floor, and because it's come up a few times, and, so that we can support our women. And then also next month we will continue. Hopefully we will have a plenary session on why, as Black people, we tend to have poorer health outcomes. And we have the Director of Health Inequalities, who is a Nigerian, Dr. Bola, and a GP as well, will be coming on. But it's great to see Dr. Ugo on the call as well. And, we're grateful to all our doctors. And Ngozi, like you said, we've been to 3-4 meetings this week, in itself. So yes, watch this space. We've launched a Black Health Improvement Program. So that's a training for all GP surgeries and their practice staffs. Well, GPs and their practice staffs across, Greater Manchester. We're very grateful to, Dr. Omofuma and Dr. Ugo for their initial support. We're hoping, to meet again, and, it's something we're hoping will begin to bring about some changes. So thanks. And until we meet on Tuesday, or come back next Saturday, so Tuesday evening, for the vaccine session as well, take care, hands, face, space, and, we will get the slides from Dr. Bim's. We will put it on our website together with the slides from last week, and keep drinking your water, as we've been told, and, all shall be well. So have a lovely
pelvic floor exercises.
Absolutely. Keep squeezing, girls. Keep squeezing.
Floor exercises.
Yeah.
Okay.
Great.
Have a nice afternoon.
Thanks.